Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is sponsored by Takeda. The AASM released a new clinical practice guideline on insomnia entitled Combination Treatment for Chronic Insomnia Disorder in Adults, an American Academy of Sleep Medicine clinical practice guideline. So this is not an update to a previous guideline, but rather is a new one that perhaps better represents what happens in clinical practice, where a sleep clinician may consider both CBT-I and pharmacotherapy for the same patient. Dr. Daniel Buysse is a distinguished professor of psychiatry, medicine, and clinical and translational science at the University of Pittsburgh School of Medicine. Dr. Todd Arnedt is a licensed clinical psychologist and professor of psychiatry and neurology at the University of Michigan. They were both on the Clinical Practice Guideline Committee and are here to review this new guideline from the AASM. Welcome. Glad you could be here today.
Thank you.
Thanks for having us.
So maybe we should start by telling me why this updated guideline is important.
So this guideline, I think, is important because it reflects a large portion of clinical practice in the treatment of insomnia patients. We have previous guidelines regarding cognitive behavioral therapy and other forms of behavioral and psychological treatments. We have a guideline that addresses pharmacologic treatments. But the reality is that in clinical practice, those two kinds of treatments are often used together, and we didn't have a guideline.
Yeah, it's funny because I know we've had guidelines in the past that said, right, CBT-I is a preferred modality. And I think there's some data showing us that by the time somebody sees one of us, right, sees a sleep person, they want the drugs, right? They often will request medication. So how does this new guideline help us navigate this?
I think this guideline really becomes a starting point for a conversation between a provider and a patient. Our previous guidelines, as Dr. Buysse pointed out, were about individual treatments, and this is information on combining these treatments. And it allows the clinician to expand the conversation beyond what one treatment does versus another to how they might fit together. So I think that's where it starts. It begins a conversation. And certainly these guidelines do recommend and reinforce that CBT-I alone is the preferred treatment. But they also suggest, I think, one of the primary messages that hopefully it conveys is that if you are going to start a medication treatment, that to the extent possible, it's good to start it alongside a cognitive behavioral treatment or another behavioral psychological treatment, that we want to get away from having providers deliver pharmacotherapy in isolation.
So, and I'm not sure I realize this, but Dr. Buysse, you mentioned that patient preference wasn't reflected in the original practice guideline. Tell me about this.
Well, I think that as the methodology for developing guidelines continues to be refined and improved, people have recognized that we need to consider the ultimate consumer, which is our patients. And so, again, we've just had guidelines that have developed, become more sophisticated, and recognize that clinical reality.
And so I will assume that this was an AASM directive to develop the guidance. So how did it go? Did you choose the committee members? How much say did you have in it? Tell me about the process.
Dr. Buysse had all the say.
Why doesn't that surprise me?
Yeah. We deferred to that. No, that's not true.
If only that were true.
Yeah.
But as you said, it was the American Academy of Sleep Medicine's board of directors that came up with the topic, decided that this was an important thing to take on at the time. And so the board asked Dr. Arnedt and myself to head up the task force. We had some input in selecting other task force members who were selected in order to represent a range of clinical practice, including people who were expert in the development, testing, and application of behavioral treatments, and people who are physicians and treat people with medication. So it was really, I think, a well-rounded committee.
Oh, so that's interesting. So
Yeah.
psychologists, and it
Hmm.
sounds like, and sleep clinicians, but also like a methodologist then.
Yeah,
Yeah.
that which I think was another key thing
Yeah.
is that we had experts in grade methodology who really steered the process and were essential.
It kind of lets us off the hook a little bit, huh?
Yeah, I think we had a nice, sorry to interrupt you. I think we had a nice representation of people who were primarily clinical providers too, and then some individuals who are more on the research side. So we really had a broad scope of expertise and knowledge around the table. And as Dr. Buysse pointed out, having that person who was an expert in the grade process was just instrumental to helping us push through and execute in an evidence-based way. And we should never forget that the ASM staff member, the amazing ASM staff member, Suzanne Heyer, who really kept us all on track, kept the project on track, and kept us all accountable. We really couldn't have done it without her as well.
They're kind of
Agreed.
amazing, aren't they? The ASM folks.
Oh, amazing.
Yeah,
Yeah.
Yeah, they.
Suzanne. Yeah, Suzanne. I absolutely agree with Todd that she was just instrumental. And before her, Uzma Kazmi had also been
Mm,
working with the task force. And again, the two of them were just were great.
yeah, they keep the train on the rails, don't they?
Mhm. For
So
sure.
let's go through the guidelines. So I'm going to read this one. The first one is a conditional recommendation for in adults with chronic insomnia disorder. The AASM suggests the use of combination treatment with CBT-I plus insomnia medications over insomnia medications alone. And they said conditional recommendation, low certainty of evidence. Talk to me about this.
All right. So the conditional recommendation and the low certainty of evidence
Yeah.
reflect something that we all suspected we were going to find going into this, which is that despite the importance of this topic, there just is not a large body of evidence from clinical trials. And the low number of studies, the varying methodologies, all contributed to having a low certainty that what we were seeing from the meta-analyses or the individual analyses were really robust findings. But having said that, I do think it's important that on all the outcomes the task force felt were most important, starting with global measures of insomnia severity, the evidence seemed to weigh in favor of combination treatment over medication treatment alone.
And so is this, so just to make sure I understand, is it as straightforward as it seems? CBT-I plus meds better than meds alone?
That is a straightforward interpretation of what the recommendations are, but it's important to note is it is a conditional recommendation, and that the low certainty of the evidence in part drove us to a conditional recommendation. The conditional means that, in a sense, while most patients should be offered this course of action, it's important for clinicians to consider patient level factors that might drive
Hmm.
a decision for an individual patient.
I mean, that's
Uh,
fair, right? Sort of that patient centered and patient sort of goal directed therapy, that sort of thing, right? So when you talk about medications, um, what were they? Like, did you look at DORAs? Is this sort of the zolpidem group, trazodone?
This is really an important part of the guideline. Was that again we could only use the data that have been published,
Mm,
and the
yeah.
data that have been published included studies that are quite a bit older. Some of the studies are from countries other than the U.S. So the actual medications involved in these studies were loramitazepam, not available in the United States, temazepam, zolpidem, zopiclone, not available in the United States, although we do have S-zopiclone, and finally one study with trazodone. So it
Huh.
was only 5 medications, 2 of which are not available in the United States, and
Ah.
that's kind of the evidence base. And again, when
mhm.
you consider the low certainty of evidence, keep in mind that the number of studies was small and the medications varied among these studies. So we had no ability to distinguish between different types of medication or specific medications within a class. And
Mm.
DORAs, to your point, um, DORAs were not included in any of the studies.
Ah, that'll be interesting, right?
So that's an important direction for future research is
Right.
we had to clump all of the medicines into insomnia medications writ large as a group and couldn't speak specifically to classes, although there's obviously a lot of interest in, and it's very possible that different medicines, when combined with behavioral treatments, have different benefits and harms. And so that's important to know, but we just didn't have the evidence base to be able to make those judgments.
Yeah, that makes sense. I know when we were preparing for this, you mentioned something, and maybe it was in passing, but you mentioned that when we talk about medication studies, they're pharma studies, right? And so the methodology might be a little bit different. Talk to me about that.
So when you look at medication studies generally in the literature, if it's medication only, there's a pretty good chance that the study was sponsored by the manufacturer of that medication as part of the FDA registration process. And that process includes very specific guidelines on how to do a clinical trial for insomnia medications. I think the most important part of saying that is that those methods are often quite a bit different than the methods that are used in RCTs involving cognitive behavioral therapy for insomnia. Right. So just to take one tiny example,
Yeah.
in pharma studies, they're supported as registration trials. The standard is to conduct polysomnography with an 8-hour fixed time in bed. When you're doing CBT-I studies, the whole point of CBT-I is that you need to vary time in bed, right? So you would never consider an outcome measure in a CBT-I study as including a fixed 8 hours time in bed, right? So the combination treatment studies were most often done by independent investigators who kind of had to include the methods for both CBT-I trials and pharmacologic trials and combine them into something that could be applicable to both.
Well, and so I've kind of been thinking about this. We know there's a decently high placebo effect, right, in pharma studies. So how do you navigate this?
I'll give that one to you.
Yeah, at the level we were at, we weren't able to navigate it because that's something that you have to build into a study design to account for the placebo effect. And I think that's one of the strengths of some of the pharmaceutical studies, pharmacological studies that have been conducted, is that they do recognize that there is a strong placebo effect. And so they have typically what's called a run-in period where people are on placebo, but they measure them at different time points and eliminate people who exhibit placebo effect from the trial. Behavioral studies historically have not done that. And I think it would be a benefit to future behavioral studies to consider implementing something along the lines of a run in and to factor in at least the placebo response that many patients have to both medications, but also to behavioral and psychological treatments.
Oh, that's interesting.
But at
Okay.
our level, we had the data in front of us and the studies were done. And so we don't have a way to navigate that placebo effect.
Right.
It's a design issue that needs to be done further upstream.
Okay, that's fair. That's fair. So when you talk about combination therapy, what does that mean? Is it sort of drugs first or like at the same time? Or do you sort of have them fill the prescription while they're waiting for their CBT-I appointment? Like, what does that look like?
In our hands, the way that we approach this guideline, that was an early on decision we had to make. We had to
Okay.
have a discussion as a committee about how we were going to define combination therapy because you can define it in various ways. And where we landed was that we defined it for the purposes of this guideline as the concurrent initiation, i.e., at the same time of a medicine and a behavioral psychological treatment. And that was largely because most of the randomized controlled trials we wanted to use to the extent possible the highest grade evidence. So randomized controlled trials generally followed that kind of process where people would initiate concurrently the behavioral and the medication treatment. We recognize, though, that in practice, sequential treatment is often, as Dr. Buysse said off the top, often more commonly practiced. But in the first of all, there are few sequential designs, randomized controlled trial studies. And secondly, there are methodological issues often with those designs around lack of randomization or lack of information about baseline symptom severity. So there are methodological issues that can downgrade sometimes the quality of those studies. And so, in an effort to use the highest quality evidence, in part, we defined combination therapy as the concurrent initiation of the two treatments.
Okay.
Dan, Dr. Buysse, do you want to add anything to that?
Yeah, I mean, these are really important points and well explained. I think maybe just to give a little vignette of the kind of study we couldn't do, yet one that would be relevant to clinical practice. We came across studies that said, okay, we're going to take people who have been treated with medication but are still symptomatic, and now we're going to give them CBT-I.
Okay.
How much do they improve? Okay, so that's a sequential design. The problem is we don't know what their symptoms were before starting the medication. So did they have absolutely no response? Did they have only a 30% response? So we can't understand, we couldn't figure out like how much improvement did they have on medication alone, and then what did CBT-I add, right?
Interesting. Okay.
All we could say is that among people with medication who remained symptomatic, CBT-I had this effect. So anyway, those kinds of considerations make it really difficult to understand in a rigorous way the effects of sequential treatment.
What about the other way around? Have you looked at people who did CBT-I first and maybe still had symptoms and then just wanted the medications?
Again, clinically relevant, but not something
Okay.
I think, Todd, you can correct me if I'm wrong, but I think there were far fewer of those sorts of studies. So again, relevant to clinical practice, but not something that we could really comment on, and a sort of study design that would be useful to conduct in the future.
Okay. Fair enough. So other thoughts about the first recommendation?
I think the recommendation to use combination treatment over medication alone has some important implications in that we often forget that medication treatment is itself something that involves behavior and behavior change, right? Taking a pill is a behavior.
That's true.
And,
okay. I haven't
right.
thought of it like that. Okay.
Yeah. And if you give someone a medication for insomnia and you give them absolutely no instruction about how to take it, number one, that's not good medical practice. Okay. And number two, you may run into the situation where it's just not effective. So what's more useful is you would tell the person, this medication should be taken at this time, this close to bedtime. And, you might even go further and say, and your bedtime should probably be no earlier than X, right?
Mm-hmm.
So imagine that. If you give two patients a prescription for Zolpidem, 10 milligrams, one of them takes it at 6 o'clock p.m. every day and comes back and says, Doc, this medication doesn't do anything. The other one takes it at 11:30 and says, wow, finally I have something that works. Same medication, same dose, same disorder, different outcomes, because the behavioral instructions were different.
Well, and isn't it funny? Because I think if you emphasize that this is what we want your bedtime to be, this is when we think you should take your Zolpidem, you're also encouraging that sort of routine, right? That consistency with bedtime, which is such a huge part of this.
Right.
Okay,
That's
so that is a little behavioral part. Okay.
It is. Right. Whether or not people pay attention to it, there's always some behavioral treatment.
Absolutely.
That's fair. Well, it's kind of like even if we look at CPAP adherence data, right? Like the people who have a routine built in with it they have better adherence, right? If they clean it in the morning and fill up the water at night and it's part of their wind down routine, then they seem to have, do better. Okay.
I was just going to reflect on my point earlier that one of the implications of our recommendations is that we would encourage to the extent possible that providers get away from providing medication in isolation, but instead facilitate as much as possible CBT-I or some behavioral treatment alongside that. And so there are digital CBT-Is available if people don't have ready access to somebody, a trained provider, there are digital CBT-I available. There's now obviously telehealth that increases access. And there are organizations like SciPact, which is a psychological organization that allows patients to get treatment across state lines. But I think another implication of, or another reflection I'd have is that the recommendations also speak, the social determinants of health are an important factor in the feasibility of somebody getting CBT-I. Like cost is an issue for a lot of people. Coverage is an issue for a lot of people. And there are a variety of other access issues that we still have to continue to work through in order to make this treatment sort of equitably available to as many people as we can.
Yeah, 100%. That's the first question everybody asks about CBT-I. Will it be covered?
Yeah.
Yeah, that's very true.
So advocating for coverage is
Yeah.
super important, right?
Yeah.
Continue to advocate insurance companies for coverage here in the US.
Yeah. Yeah, because it kind of does turn into, even with medications, right? Like our options are a lot of the times limited by what the payer will cover, right? And then government payers not accepting the prescription reduction programs. And so then you kind of have almost two categories where people whose insurance will allow for newer medications have so many more options than people who don't, right? And it is an equity thing, isn't it?
Very much so.
So let's take a short break, and when we come back, we'll talk more about the clinical practice guidelines for chronic insomnia. You're listening to Talking Sleep from the American Academy of Sleep Medicine. Welcome back to Talking Sleep. We're talking with members of the Clinical Practice Guideline Task Force about the new AASM guidelines on chronic insomnia. So I'm going to read the second one. Okay, and it took me a minute to kind of understand it. Okay, so it said, conditional recommendation against. And then it says, in adults with chronic insomnia disorder, the AASM suggests against the use of combination treatment of CBT-I plus insomnia medication over CBT-I alone. And this was a conditional recommendation, low certainty of evidence. But then there was also this remark that said patients who place higher value on increasing total sleep time early in the course of treatment and or who place lower value on reducing daytime symptoms with treatment may reasonably select combination treatment versus CBT-I alone. So the remark, right, is very clearly patient directed, right? Help me understand the recommendation though. So CBT-I plus meds, better than meds alone, but CBT-I alone is still better?
Right. That's kind of the take-home point, right? That you can imagine lining them up, kind of CBT-I better than combination, better than medication alone. That's the recommendation. And that's what it reflects. So the low certainty of evidence and conditional recommendation are similar to what we had said for the other questions that we address in this guideline, in that the number of studies is small. The effects are variable between studies, and together that meant that in many cases, the difference between treatments didn't kind of meet our clinically significant threshold, right? But to the extent that we could kind of infer any difference between the treatments, the outcomes generally favored CBT-I alone over combination treatment. So
that really surprises me.
Yeah. And then the comment part, though, acknowledges that on a few of the outcomes, for instance, total sleep time was actually a little bit better with combination treatment. And that, again, may not be surprising because early in the course of CBT-I, you tend to restrict time in bed. That may result in a little bit lower sleep time. Medication may counteract that. The other part of the comment had to do with daytime symptoms, and this is an unfortunate kind of double negative here. But the finding was that combination treatment had a bit more daytime. People didn't improve as much on daytime outcomes with combination compared to CBT-I alone. Okay,
they did not.
They did not improve as much on a combination of CBT-I alone. But if you have someone who says, I'm not really troubled by daytime symptoms, all I care about is sleeping longer, okay, that person might reasonably choose the combination. If you have somebody who says, I don't like being awake at night, but what really troubles me is that I can't think during the day and I feel awful, that person, you might want to stay away from the medication combination.
Is it because they're sedating? or because CBT-I is just that much more effective?
I don't know that we can really. I don't know we can really say. All we can say is that the daytime symptoms didn't improve as much
Okay.
in the people on combination treatment.
And you do have patients sometimes. Seema, I was going to say off the top, it
Yeah.
took you a while to understand that. It took the committee a while to write, especially that remark, to figure out how to write the
Mhm.
remarks that we were communicating the right thing. And
I won't
it
admit how
does
many
add
times I read
nuance.
it.
Yeah. I think the phrasing is a result of because we're interested in the combination treatment. So that sort of goes first, and that's why it's a recommendation against. But
Oh,
um,
okay.
I think that it adds nuance. The remark adds important nuance, I think, and we do see patients who sometimes are more bothered by sitting awake at night because their partners are sleeping and it really bothers them, and they don't feel so impaired during the day. And then you have other people who really feel impairment during the daytime. So you have the opportunity to have that discussion with your patients
Okay.
and set determine patient oriented goals and then drive the treatment accordingly here. And similarly with total sleep time, sometimes people are come in very concerned about lack of sleep, or they value that, especially early on in treatment, as something that's important to them, or they work in an industry where adequate sleep is
Mm,
really important. And so then that may rise up in terms of importance initially early in treatment. And
okay.
therefore, somebody like that might choose combination
Yeah.
treatment over CBTI alone. So it adds a little nuance, a little complexity to the recommendation, but does also allow for flexibility, I think, in
Oh,
the
that's
context
Yeah.
fair.
of working
Yeah.
with patients.
I was thinking about a patient I actually saw yesterday for the first time who has insomnia, not currently on medications, hasn't had CBT-I before, kind of someone rare in my clinic.
Oh, I suppose,
But
yeah.
there she was, yeah. And what she said two things that struck me. One is that she said, I just want to try to get 7 hours of sleep because when I get 7 hours of sleep, I feel so much better during the day. I'm less irritable and I'm more productive. So how do I use this guideline here? She wants 7 hours of sleep. She places a high value on total sleep time, but she's very concerned as well about daytime function. So that
Yeah.
would suggest, well, maybe CBTI alone. So again, she actually placed
Huh.
value on both of those things, but on balance, and because she was interested in not using medications if possible initially, on balance, I kind of placed a little more emphasis on the daytime thing, and we went with behavioral treatment alone initially.
Oh, that's interesting. I hadn't considered that they are a little bit, right? Okay, that makes more sense that they're not always, um, like the same patient can have both of those concerns.
Yeah.
Yeah, and then you have to sort of prioritize which one they want to do first, plus consider whether they want to be on medications or not. Yeah. Huh. So, do we know if the order matters in terms of meds first, then CBTI, or the other way around?
So this is actually, yeah, it's outside of the,
Mm-hmm.
the clinical practice guideline per se, but as we've been saying, we encountered a few studies with sequential treatment, and probably the best one, at least in my opinion, is one by Morin and Ettinger. They did a truly sequential treatment
Okay.
study. So they had at the first sequence, it was behavioral treatment or zolpidem, and then they looked at whether people responded, and then the non-responders were randomized to a second treatment. So the zolpidem people had behavioral treatment added, or they were switched to trazodone. The people who had behavioral treatment initially either had medication added or they had cognitive therapy added. So at the first level, kind of head-to-head behavioral treatment and the zolpidem. I've set the study up nicely. If only I remembered the results. Really,
I can pick it up.
do you remember?
I do have the results there if
Yeah.
you
Okay.
want
Go ahead.
some help with that. So at that first stage between behavioral therapy, zolpidem head to head, there was no difference in terms of responders or remitters.
Okay.
But I think what was interesting, and I don't want to steal your thunder, Dan, at the second stage, but The group that did the best was when you added one of the either cognitive therapy or zolpidem to behavior therapy. So if you started with behavior therapy first and you didn't have a response, but added either another behavioral therapy, cognitive therapy, or zolpidem, that group did the best. And it's interesting and a little bit ironic to me because typically sequential treatment is done the opposite way, where you would start
Mm.
with a medicine. I think the most common way we would see it in the real world
Yeah, yeah.
is you would start with a medicine, and then if people didn't respond, then you would add a behavioral psychological therapy. But in fact, Morin study suggests the opposite works better.
Okay.
Now that's one study, a very
Yeah.
rigorous study, and of course more data
Yeah.
are needed, but it's
Right.
kind of interesting.
But also, yeah, it was the best study, but also still with fairly small numbers. So anyway, it's clearly an observation that need or set of observations that need to be replicated and extended.
But so Todd, you're a psychologist, right?
I
And
am.
so you very clearly distinguished between a behavioral intervention and a cognitive intervention. Whereas I think for us, you know, non psychologists, or at least as a pulmonologist, I put it together as cognitive behavioral therapy.
Yeah, well, that's typically how we deliver it as a
Yeah,
multi-component treatment, but it's a
yeah,
CBT is a multi-component treatment that involves a cognitive component, a
yeah.
behavioral component, and then often other things like sleep hygiene and other additives to that mix. But the core components are a behavioral component and a cognitive component. Now they're
So
often,
the cognitive is sort of
it's
challenging beliefs about sleep, and then
right.
the
The
behavior
cognitive
is
really
what?
involves, yes, trying to understand beliefs people have or look at thoughts that get in the way of sleeping
Yeah,
and either work to have them think differently about those thoughts so they don't interfere with their ability to sleep.
yeah.
Or other approaches might be to just recognize the thought and kind of let it be. That would be a different approach. But the cognitive behavioral approach would be to identify the thought, identify why it's unhelpful, teach the patient why it's unhelpful, and help them to change the thought into something that doesn't distress them. That's the cognitive component of it.
What was the behavioral component in that study that they did first?
Yeah, the behavioral component would have been sleep restriction
Oh, sure.
therapy
Okay.
and
Okay. Okay.
stimulus
Okay.
control therapy. Those two together would be the behavioral component. So you can break them apart, and I think
Yeah.
that's in many ways a future of where we're going with and psychological treatments is trying to understand how the constituent components work separately and how they work for different populations. But in that study, they did break it apart into behavioral and cognitive.
Yeah. Okay. I'm not sure I realized that the first time around that they had broken that the behavioral was okay.
Mhm.
Ah, look at all this beauty inside CBT-I, huh?
No, the reality is though that they're not totally separate because I
Okay.
think behavioral change can also lead to thinking changes. They don't really happen
Yeah.
in isolation, and thinking changes can lead to behavior changes. So I think that it's very hard to actually fully separate them
Mm.
in reality.
Okay, so I will say, and I think I kind of know what you're going to say, but the question I really was curious about is just about the medications, right? Like I recognize that you put them all in one group of 5 medications, 2 of which we cannot access in the US. Um, but is there an order that we should follow for medications that isn't sort of determined by insurance? Like, how do you know who gets what?
Probably there's an order we should follow, but we don't really know. That's again, it's a really good question, and it's we are in a very different situation with insomnia treatment than we are with other medical problems like hypertension, just to take an example, right? Where there is
Yeah.
a very clear step through procedure, and there really is not with insomnia treatment. We really have I don't know that in the big picture, we have like three main classes of medications that we use, right? Things that affect benzodiazepine receptors, things that affect orexin receptors, and sedating drugs that affect serotonin and norepinephrine and other receptors, right? But we do not have a clear sense of which one should be used first, second, and third, and in which combinations. And partly that reflects something that we were talking about before, which is payer decisions.
Mm-hmm.
And partly it involves patient factors, right? So it would be okay for me to say, well, first line should be a benzodiazepine receptor agonist. But we have to put a huge asterisk, except in people with a history of alcohol or other substance use or, sensitivity to it.
Yeah.
So we just don't have that algorithm yet.
Yeah, it's interesting, right? Because I think sometimes there's a little bit of that art, right? The art and then the science and sort of, and you pick up little snippets. And I'm sure Dr. Buysse, I've picked up some of these from you at some lecture somewhere about, coexisting sort of anxiety and insomnia. Maybe, you think about trazodone and you think about, whatnot. And I've always kind of been curious, like, where does Romeltion fit? I heard you talk about GABA. I heard you talk about orexin. Where's Romeltion fit? The melatonin receptor.
On the shelf.
Stop. Actually?
In your dreams.
Well,
What happened to those Romeltion ads? Those were the best ads ever.
I don't remember them.
The Romeltion ads were good. I think the issue with Romeltion is that it only ever was really demonstrated to be efficacious for sleep onset insomnia. Right?
That's fair. Yeah.
And I think most insomnia patients really have a combination of symptoms. If not now, then at some point, right? So the number of people who have pure sleep onset insomnia only is rather small. And among those, you have to make sure that you're not dealing with delayed sleep phase disorder instead, right?
Yeah.
So I think it has, fairly limited utility, and I think I'm sure that there are arguments that could be made for why Romeltion would be preferable to melatonin itself. I mean, they're both, melatonin receptor agonists. But if there's an argument for it, I think that the argument has been lost on most people. So why not just use melatonin? I think is most people's response.
I mean, that's fair. That's what patients always say. Yeah. Okay. And so, Todd, you had said something I think really, really important about equity and access to CBT-I. And you kind of talked about digital CBT-I and telemedicine CBT-I and in-person CBT-I. What do you recommend? I live in a rural area and I usually will offer, I have a list, right, of all of them. And I try to leave it up to the patient. But I feel like people are more likely to engage with somebody telemedicine or in person than via an app. But I don't know if that's just me and my patient population.
I think we don't fully understand which patients benefit from which types of treatments. I think that we still default to the ones that we started with, which were in person and face to face. And telemedicine, there's evidence that telemedicine does as well as face to face. There are a few comparative efficacy studies looking at that. But I think that the digital CBT for insomnia apps have come a long way, and they have medium to large effect sizes for improvement on insomnia. But they can suffer from. There is some evidence that when there's clinician involvement with those, patients will sometimes do better as opposed to totally asynchronous kinds of apps that people are doing on their own.
Okay.
But I think there are also some people who do just fine with asynchronous apps and if can be motivated to complete the treatment and do well with those. So I think we don't fully understand the patient factors involved in who's going to do well with which format of treatment.
Yeah.
But there still is a shortage, despite the fact that we've made progress on all of this. I think there still remains a shortage of access for patients who really need this form of treatment.
Well, and so access meaning two things, right? Like we need more trained people, but then it also has to be reimbursed better to get more clinically trained people. Yeah.
True. Yeah.
Yeah.
Absolutely.
So what do y'all do for improving access to CBT-I?
Us all?
Yeah.
One of the things we've done is we haven't talked about group format yet. So we
let's talk about that.
Deliver CBT for insomnia in a group. It is a very amenable treatment, I think, to a group setting because It's like a health behavior, and I think people benefit from understanding that they're not alone with their insomnia, that many people suffer from insomnia out there. And also, if there's kind of a kindred spirit if you're engaging actually in something like sleep restriction therapy to go through that with other people, and they can give you support and help give you ideas about how to, for example, stay awake past your normal bedtime and what kinds of things are helpful. So I think CBT really does lend itself to kind of a group format. So that's one way we have dealt with in our academic medical center with access issues. And then we have leveraged digital kinds of apps too, to give people. And again, I wish I had better understanding of who is going to benefit at the front end from these, because I've sort of used clinical judgment in
Mm.
who I might recommend that as an option to. And I don't know how good my clinical judgment is. I think you get varying opinions depending on who you ask.
Hmm.
Um, but that's another way we've tried to deal with the access issues. And then, I think I mentioned SciPact earlier. That's a psychologist-based
Yeah.
organization. That does allow, you're right, we have to increase the number of trained providers.
Hmm.
Um, but SciPact does allow a psychologist to be able to provide a treatment across multiple state lines. And so that allows there to be, I suppose, fewer number of trained providers who can provide
Yeah.
services to a larger group of people. So that's beneficial. But it's not enough. We've got a long way to go, I think.
I wish we would learn from you and have something equivalent for medicine, for physicians.
Yeah.
Yeah.
I think just some other perspective on what Todd said, all of which I agree with, and I think that's a great model that he's talking about with group intervention. I also think that if you look at the number of people with insomnia in the United States and
Mm.
the number of accredited behavioral sleep medicine providers, there's a gross mismatch. I did the math at one point and figured that Todd and all of his BSM colleagues would need to treat 38,000 people to get
Wow.
through the number of people with insomnia in the United States in 1 year. So again, increasing providers, definitely, but it's not going to address the whole problem. And I think that one direction that we could really fruitfully go is in the direction suggested by Colin Espy in the UK, who's really advocated for a stepped care approach. And the reason I think that is useful is that not everybody with insomnia has an equally severe problem, and not everybody is going to need as intensive an intervention. So if you could imagine stepped care being, high quality, standardized educational materials at a very basic level, maybe stepping up to either online CBT-I or something like that, and then maybe
Mm.
in-person brief behavioral treatment, and then maybe group CBT-I, and finally like individual CBT-I. There are all sorts of levels that would better match potentially the magnitude of the problem. But we have a long way to go to get there.
I mean, that's a really good thought, though. So everybody starts here, and then you kind of, if you still need higher levels of care, you just advance. Okay. All
Yeah, I mean, one of
right.
the nice things is we do have nice rigorous measures to be able to evaluate how people are doing. Like we have cutoffs to define validated cutoffs to define both a responder and a remitter to treatment. So, and quick and dirty measures that patients can fill out, so we can
Mm.
start to integrate that into kind of a step care model to understand who needs those higher levels of care. At least that could be one measure
Oh,
that
that's a
can
good thought. Yeah.
be
Yeah, that makes
used.
sense.
I should say
Okay.
too that
Yeah.
I'm wearing on my right hand and arm here a variety of devices, and what we're seeing very rapidly and unsurprisingly is that consumer wearable companies are getting into the business by with AI
Yeah.
models that are based on a person's sleep patterns and give feedback based on the work that Todd and other people have done with CBT-I, so that it's kind of bringing AI agents to your home and to your phone, And for some people, that may be, that may be a good solution,
Yeah.
right at the very early level. So that's yet another possibility here.
Right. So, like, what's the next paper going to look like? Probably talk about Doras, talk about AI, talk about wearables. Yeah.
Yeah,
The AI models will only be as good as the data used to train them. So
Right.
that's a call
right.
for much more data to examine some of these critically important questions.
Yeah. I think that the next paper is going to really depend on new data
Mm.
that it can be based on, and hopefully this guideline and the systematic review and meta-analysis that accompany that, hopefully that will serve as kind of a call to action in our community and with funding agencies, NIH and PCORI, to recognize that there's this mismatch between what people need, how they're actually being treated, and the evidence that we have
Yeah.
to really judge the utility of those treatments. So we need to do more sequential treatment studies. We need to use updated medications. We need to use updated therapeutics for CBT-I, right? There's definitely work that needs to be done.
Mm. I'll ask you each for a key takeaway for us. Dr. Buysse?
My key takeaway would be patients with insomnia should first of all be treated with behavioral or cognitive behavioral approaches and use medications for specific patients who really either can't or won't use behavioral treatments. And either of those approaches is better than giving someone a prescription with no instructions at all. That's definitely the kind of
That's fair.
the lowest level of recommendation that I would offer.
That's fair. Dr. Arnett?
I guess I would add to that one thing that maybe we didn't touch on. Yeah, we couldn't speak to any combination treatment that involved anything other than CBTI, right? But there
Mm.
are other behavioral treatments.
Okay.
There's single component treatments like sleep restriction
Oh,
therapy,
sure. Yeah.
stimulus control therapy. There's third wave interventions like mindfulness, ACT. We need to have be researching all of those, but sleep hygiene doesn't count as a behavioral therapy. So we're not suggesting that you give a prescription and that you also give sleep hygiene and you've done combination therapy.
Right.
You've given it a behavioral therapy, because in our clinical practice guideline from 2021, we recommended against sleep hygiene education alone. So
Yeah.
if you're going to not use CBTI, it's important to pair pharmacological therapy with an evidence-based, either multi-component or single component therapy, behavioral and psychological therapy, and not sleep hygiene.
Yeah, that's important, right? Because everybody already knows sleep hygiene by the time they see us, right?
Do
Yeah,
That's
and I
all
they?
think
over the internet.
Do they?
Really?
So
You
right.
don't think so?
do they?
Do they?
We
Oh,
recently had a
This is
discussion about this,
yeah,
Dr. Buysse and
yeah.
I.
Well, what is sleep hygiene?
tell me. So, what are
I don't
your,
know. That's the whole problem. That's the whole problem is that if you and people have done
yeah.
meta-analyses of
Okay.
this, if you look at papers that purported to use sleep hygiene as a treatment,
Yeah.
the problem is that no two of those papers include the same elements. Sleep hygiene is not one thing.
Huh.
It's just a collection of things that occur to people, but it's just never the same thing. I honestly, I wish that professionals would stop using the term sleep hygiene at all, because it means everything and nothing.
I didn't realize that, because I guess in my head, I have a very
Yeah,
specific idea of what sleep hygiene means.
you do. It's just that what your clear idea is
Yeah.
not necessarily the same as someone else's clear
Okay.
idea, right?
Okay.
And there are several problems with it, but another one is that it's totally not individualized. So you can give a person a sheet with 15 sleep hygiene tips on it,
Yeah.
but the first one, to not use caffeine, is totally irrelevant to a person who's already not using caffeine,
Yeah, that's fair. Yeah.
or a person who's not using alcohol, right? And I think that you are right, though, that most people with chronic insomnia who get to a sleep clinic, okay, they
Mm-hmm.
have read all the variations of sleep hygiene advice and they have applied them to the best of their ability or interest, and have mostly found that it doesn't solve their sleep problem. So their conclusion, unfortunately, is that, oh, sleep hygiene doesn't work, or even worse, they say, oh, I tried CBT-I and it didn't work. When in fact they didn't try CBT-I at all. They just equated some, sleep hygiene tips with CBT-I. So I think there's, I wish that as a field we would stop using it.
Well, I mean, if Dr. Buysse says so. Well, thank you both for joining us today and really helping us to better understand the new AASM clinical practice guideline on combination treatment for chronic insomnia disorders in adults. You clearly did a lot of work analyzing existing data and then adding the patient preference piece, while also considering how various clinical practices may differ in their approach to chronic insomnia in adults. So thank you both for being here.
It's a pleasure.
Thank you. Yeah, it's been a pleasure.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.